Good morning, everybody. How's everybody doing today? I know it's early, and we want to thank everybody for coming, and we are sure that you had an opportunity to get a little bit of breakfast downstairs. I want to welcome all our faculty, staff, alumni, guests, and students. And it's with great honor and privilege that we have quite a list of panelists and moderators here today to discuss this issue about the opioid epidemic. First of all, I'm going to welcome the Chief Academic Officer to give a few remarks. But prior to that, I want to just mention a few things to keep in mind that really suggest how timely this event is. So about last week, President Trump declared that the opioid epidemic is a national emergency. And we know that about 64,000 Americans perished from drug overdoses last year in this rapidly worsening national crisis. That was a quote from Elijah Cummings on his press release recently. And so, as I said, we have experts and leaders who are here today on the subject, and they're seated right here, and you'll be hearing from them throughout the day. We have folks from legislature to talk about treatments. We have folks who will be talking about the practitioners' work and innovation around the subject. Community leaders as well will be present to do some discourse around what types of solutions we'll have. And then lastly, we will have some of our students come together and really in some interdisciplinary fashion say, this is what we're going to do. Our hope is that at the end of today that we will have some solutions that we can put together to be able to formulate policy to address the opioid epidemic. So, without much ado, it is my pleasure to welcome to the stage the Provost and Chief Academic Officer as he brings greetings on behalf of the President. Please welcome Dr. Anthony K. Wuta.
Good morning. I want to thank Dean Tafati for welcoming me and giving me the opportunity to greet each of you and welcome you to Howard University on behalf of our president, Dr. Wayne A.I. Frederick. This is really a significant occasion as we focus attention on this very significant issue. This year, Howard University is celebrating our 150th sesquicentennial anniversary, and as we look at the scope of the opioid epidemic across this country, what is significant in this particular symposium is the breadth of expertise that we have brought together to focus attention on this issue, and the breadth of our faculty and student expertise that are engaged, not just our health sciences programs, the School of Social Work, the School of Divinity, the law school, which really speaks to the over-encompassing and overwhelming, it seems, issue at hand. I think this issue was really brought even more in focus in the national agenda as President Trump declared a national public health emergency. But even before that, we were in the planning phases for this program, which really speaks to the timeliness and the growing issue at hand. Before we go further, I really want to acknowledge and thank Dean Tafati and Dr. Earl Etienne for their role in organizing this event. And I also want to acknowledge our individual and corporate sponsors who are listed in the booklet, the Mid-Atlantic AIDS Education and Training Center, Pfizer, the AIDS Education and Training Center program, Cigna, Leonard Edlow, who is an alum of the College of Pharmacy, and Minnie Baylor Henry and B. Henry and Associates, who is also an alum of the College of Pharmacy. So for our students, I really hope that you take the opportunity to engage with our speakers who are national and international experts in this area. I hope that you take this as an opportunity to see a potential career option for you. I don't believe that this issue is going to be addressed in the next year or really even completely addressed over the next 5 years. And as we continue to have a growing number of patients, a growing number of individuals, a growing number of families that are victimized by this epidemic. I hope that you see this as an opportunity for you to intervene as professionals and as an opportunity for you to really gain a perspective of what this means in terms of the care of individuals that you encounter and ways that you may be able to have a direct and an indirect impact on addressing this crisis. So again, I want to thank each of you for your presence here. I know that as the day goes on that there'll be more students and more faculty and individuals who will be filling the audience, but I really hope that we will take this as just a first in a number of steps that we will need to take to continue to make an impact and for Howard University to continue to lead in ways that we have led over the last 150 years. So thank you again for your attention, and I look forward to engaging with you in this very important issue. Thank you.
Thank you, Provost. At this time, I have the distinguished pleasure of inviting to the stage our keynote speaker for this program. Dr. Steve Miller, is Senior Vice President and Chief Medical Officer of Express Scripts. He's a leading advocate for fair drug pricing, supports government relations, leads the Pharmacy and Therapeutics Committee, manages the medical affairs team, and interfaces with client groups. His expertise represents years as a medical researcher, clinician, and administrator, and spans numerous healthcare subjects. Steve has served as Chief Medical Officer since 2006. He's focused on clinical matters, including e-prescribing initiatives, specialty solutions, and overall development of products that make prescription drugs safer and more affordable. He previously was the Vice President and Chief Medical Officer at Barnes-Jewish Hospital, Washington University School of Medicine in St. Louis. He received his medical degree from the University of Missouri, Kansas City, and he trained in the Pathology and Research Fellowship at the University of Alabama at Birmingham. He was the William J. and Dorothy Kish Kerr Fellow in Cardiology at the University of California, San Francisco, and he also did an internal medicine training at the University of Colorado and in nephrology and transplantation at Washington University in St. Louis. He earned his MBA at the Olin School of Business at Washington University. Please join me in giving a very, very warm Howard welcome to Dr. Steve Miller.
Thank you very much for having me today. I'm really excited to be with you all. Obviously, as one of the people that they flew in for the event, I will tell you a little joke. So there's these three people flying across the country in an airplane, in a little private airplane. This very distinguished businessman in a really well-cut suit, an older gentleman and a young child. And as they're flying across the country, the plane starts spewing out smoke and really shuddering, and finally the pilot comes out of the cockpit. He says, "I have horrible news for you." He says, "No matter what I do, I can't save this plane." He says, "But I have even worse news for you. There's 4 of us, there's only 3 parachutes. Clearly, as the owner of the plane, I deserve one," and out he goes. So the distinguished businessman gets up and he says, "I hate to break this news to you all, but I'm a Ivy League graduate. I'm one of the smartest people in the world. I'm a lawyer, I do big contracts, and the world would be a much lesser place without me." And out he goes. So the old man and the young kid are looking at each other, and the old man says, "Listen, I've had a great life. Take the last parachute, save yourself." The young kid looks at him and goes, "Well, why can't we both be saved?" He goes, "Well, what are you talking about?" "The smartest guy in the world just stole my backpack." I tell you that just because, making the right diagnosis, doing the right thing is actually crucial as we go forward, because we've actually done a lot of things wrong. And when you think about the opioid epidemic, this epidemic looks exactly like everyone here. This has no boundaries whatsoever. This impacts young and old, white and black, U.S. born, non-U.S. born. It actually impacts all of us. And if you think about the statistics, we currently have over 2 million people addicted to narcotics in this crisis. This is an enormous number of people and their families that are suffering from this disorder. When you think about the death toll, this is the old data from the CDC, so it was old as of yesterday. You know, the CDC in 2015 said 91 people were dying every single day. The President's Commission report yesterday said if you include heroin and other drugs in this, this is 175 people dying each and every day because of this epidemic. And if you look at total cost to society, this is costing us over $53 billion on an annual basis. So it doesn't matter if you look at this in the loss of human life or in the suffering of families or the economic toll on all of us, this is a crisis of epic proportion. And it, like I said, impacts everyone. Now, these numbers won't add up to 100% because I don't include the people under the age of 25. But if you look at the 25 to 35-year-old, 26% of the crisis is within their age group. But you move to the one above that of people over the age of 55, 19% of this crisis is amongst those who are elderly. So this actually impacts all demographics. And to make this point even further, if you look at the increase across communities, there's some very interesting information on this slide. So what you see is that it impacts all the communities, but notice the switch that occurred around 2000. Prior to 2000, this was really a disease that was seen predominantly in the minority communities. And the U.S. approach to how we treat this, that is, just say no and incarceration if you can't say no, has switched as the non-Hispanic white community has become involved. So government policy is actually evolving based on who's been involved. And I'm not saying this is a good or bad thing. I'm just saying it is a fact. And as a pragmatist, we are addressing this much differently now, and it is impact, and we're not being very successful. Because it doesn't matter which community you're looking at, there's a tremendous increase year over year. And so this is a crisis that we're going to need everyone's help. And it's not just about prescribing more narcotics. If that was the case, this would be relatively simple. This is a much more complex problem than our overuse of prescriptions. But remember that most of the time it does start with a narcotic. It doesn't start with an illicit drug. It starts with a prescription drug. And for people who are prescribed narcotics for more than 10 days, there's a 1 in 5 chance that you're going to end up hooked on these drugs. These are incredibly powerful, incredibly addicting drugs, and we have got to address this in a very holistic approach. So how did we get here? And I'm going to give you my abbreviated history on this. It started actually in 1980. There was an article in the New England Journal. It was actually a letter to the editor, and it is only 5 sentences long. But that letter to the editor in New England Journal claimed that opioids were non-addicting. Think about that. 5 sentences, not a study. It's a letter to the editor, and that is the basis. That letter has been quoted literally thousands of times as the basis of why narcotics are thought to be non-addicting. So that was in 1980. In the 1990s, the Joint Commission said, we are under-treating pain. Pain is going to become the 5th vital sign. And every one of you are familiar with the smiley faces, where with your pain was horrible, you had that frowny face with tears at number 10, and if you had no pain, and you had the big smile at 0. And I, as a physician, got compensated differently if I didn't treat pain. So we would ask patients for satisfaction surveys. Those patients had to have their pain adequately treated. If I didn't adequately treat the pain, I would actually get reimbursed less well. So the incentive was for me to actually try to eliminate all pain. And as you know, that's actually not a practical approach. When you think about this crisis, America is 4.6% of the world's population. We take 75% of the world's OxyContin. We are the most in-pain population on the planet. And so what happened is we're now setting up a system where we're actually encouraging doctors, nurses, pharmacists to overtreat pain. And there was this incredible explosion of new products that came to the marketplace. Longer acting products, more potent products, and this actually created even more addiction than before. And obviously, once you get so many people taking these drugs, there's a backlash, and what we did is we saw now an explosion of non-prescription drugs, drugs like heroin, even more addicting than the narcotics. And the pharmaceutical industry came up with their solution, and their solution was tamper-resistant products. Now, it sounds great on the surface, making a tamper-resistant product, because we know that addicts love to actually snort narcotics or to grind it up and inject narcotics. The way the tamper-resistant products work is they're very difficult to grind up. And so what happens is they're difficult to inject, and you can't use a small needle. So instead of using a small needle, you have to use a big needle. And big needles are hard to get, so what do? You share your needles. And so what you see now is not only do we have an opioid epidemic, but we're now creating an AIDS epidemic and a hepatitis epidemic in concert with the opioid epidemic because of tamper-resistant products. There is no data that tamper-resistant products actually decrease addiction. But if you ask 100 addicts which they prefer, the easy-to-grind-up stuff or the tamper-resistant stuff, they'll tell you 100% of the time they like the stuff that's easy to grind up. The point is that overprescribing of tamper-resistant or traditional narcotics still leads to addiction, and the only difference is you can get it with or without HIV and hepatitis. And as you know, this has led to the price of heroin has actually gotten so low it's often cheaper than the narcotics you can buy. And so the heroin epidemic has grown, and as you know, these drugs are incredibly addicting. The likelihood of getting someone off heroin is about 8%, and so it takes incredible effort to get people treated. And now we have a new scourge coming into the system. We have drugs coming in from China and elsewhere, fentanyl and even more powerful drugs, more addicting, and actually causing even more deaths. And so this continues to be an incredible crisis, and we all are complicit in it. The physicians, the pharmacies, the distributors, the pharmaceutical manufacturers, the legislators, we have all had our fingerprints on this. We have all been part of the cause, and so we have to all be part of the solution. Everyone in this room is going to be important if we're going to have any success here. And so we're going to have to look at it not just from a medical perspective with the nurses and doctors and other providers, but pharmacists are going to have to be the sharp end of the spear. They interact with the patients more often than anyone else. A patient goes to a hospital less than once a year. They go to a doctor less than twice a year. They see their pharmacist on average a dozen times a year. And so we're going to have to make medical pharmacy. We've got to figure out how to take care of patients in home. And we're going to have to come up with better policies on how we're actually going to treat the addicted patient, but also get these products out of the marketplace so not so many people are addicted. So if you think about this in a short period of time we have to do better care at the point of service. We have recently put in place, for instance, a system for electronic prescribing of controlled substances, and we're going to get into this more in the future. But just like electronic banking has taken much of the fraud and abuse out of banking, electronic prescribing of controlled substances can have a huge impact on sharing data, having visibility to which patients are getting overtreated, and being able to cut those supplies off. We have to do things to combat fraud, waste, and abuse. The amount of pain clinics that are out there that aren't legitimate pain clinics, the amount of pain pharmacies that are out there that are not legitimate pain pharmacies, we need to identify these, close them down, and we have that information, we just have to be using it in a brighter way. I talked about pharmacy being the sharp end of the spear. We've recently put in place a program where for a person naive to narcotics, they can only get a 7-day fill. When we asked doctors, gave doctors the right. You want to give that patient more than that 7 days, you could override this. It turns out doctors have only asked for overrides 1.3% of the time. Most people with acute pain do not need a long prescription. When I had my hernia repaired, they gave me a 30-day prescription. I never even filled it. I used ice instead. The point is, it's not bad to experience pain. We have got to educate our patients that some pain is normal, and the goal should not be total pain elimination. And we need our pharmacists who are dealing with these patients to really take an active role. We have got to figure out how to support patients. How are we going to get the addicted patients off these drugs? How are we going to make these resources available? And what's really scary is that remember that 7 out of 10 people that get addicted to drugs, the prescription was not their prescription. They're taking the medicines out of someone's medicine cabinet. It's friends and family that are providing them that drug. So it's the prescription drugs are the gateway drug, but it's often not your prescription. You're finding it in the medicine cabinets, and we have got to get these things out of the medicine cabinets. On the right, you see this little bag we now provide our patients. It has activated charcoal in it. You take whatever opioids left, you put it in with the activated charcoal, you add water to it, you essentially make it non-usable. And so there are lots of give-back programs that are run by the pharmacies. There's give-back programs that are actually run by the water department because they don't want these things being flushed down the toilet. And so there's all sorts of options to get these things out of your medicine cabinet and to decrease the use. Finally, we have an enormous education task in front of us. It's not just education to practitioners like physicians, nurses, and pharmacists. It's also really important to have education for families and patients. We're going to have to do a much better job of making people understand how important it is to properly use these products. I told you about this program we put in place recently where we gave people just a 10-day fill. We did a further experiment. We can now actually predict with our data if someone will become addicted to opioids before their first prescription. Think about the power there. I can tell you if you're going to be addicted before you get your prescription. And what we did is we took 106,000 people that had a high predictive value and we randomized them. 50% of them got a letter that was just kind of a generic letter. 50% of them got a letter that said, we understand you've been started on a narcotic. Please be aware these are highly addicting. Try to get off them as fast as possible. Work with your doctor to see if ice or non-steroidals or other things will assist you. And make sure you dispose of them properly. It turns out that the likelihood of those patients getting another prescriptions for narcotics went down by 20% with just a 44-cent letter. Think of the power of that. And when we followed those patients out over the course of a year, their chance of hospitalization went down by 38%, and their chance of going back to the ER went down by 40%. This is a 44-cent letter that was able to do this because we picked the right population. This is the type of research we need to be doing going forward. These are the type of tools we need to put in the hands of doctors, pharmacists, and others if we're going to be successful in stopping this problem. And most importantly, we have got to advocate for smart policy. The policy of the past of just say no and incarceration did nothing to stem the opioid epidemic. We have got to put in place, and the President's Commission just yesterday released a report with 56 recommendations. Many of them are right in line. They're right in line of trying to get people into care. I'll give you another scary statistic. When you go out and you rescue someone with an opioid overdose with Narcan, the likelihood of that person dying in the next year is 10%. So we're rescuing those people, but we're not getting them into rehab, and we have got to do something more than just rescue them. We have got to make it a holistic system. The big drawback is, as you know, is no new dollars have been allocated for this. And the trouble is we're going to have to steal dollars from other equally important crises like the AIDS epidemic, hepatitis epidemic, and other things to take care of this. But we're going to have to be much more inventive, much more innovative about using tools that are going to help us going forward. And so as we look forward going, and hopefully what we're going to discuss today is truly that whole arc. It's the arc from education to prevention, treatment to legislation. We are going to have to pull every single lever, and everyone in this room is going to have to take an active role if we're going to be successful in stemming what I think is one of the worst epidemics of anything I've seen in my career. I'm going to end there. I thank you all very much for being with us, and I look forward to the rest of the day. At this point in time, I'm going to invite up a couple co-presenters. We're going to have our first panel. Session one is the role of healthcare practitioners in the opioid crisis. And joining me on the stage will be Ken Whittemore, who is from SureScripts, and Doug Shucklehoff, who is with the is Vice President of ASHP, the American Society of Hospital Pharmacists. So please welcome them to the stage.